Coming up on Leaders in Healthcare, Dr. David Daniels is an expert in human resources management and occupational health and safety. He specializes in the area of psychosocial safety in the workplace and has completed additional education on diversity, equity, and inclusion through Cornell University. Today's episode focuses on how we can all foster an inclusive working environment through a collaborative approach, inviting conversations about safety and addressing the hidden psychosocial risks inherent to health systems.
So a lot of organizations, a lot of social settings are hazardous because they were designed to be that. So we want to accomplish something, but we want to accomplish it in a safe and there's a difference between doing safety things and feeling safe. They're not the same thing. What's consistent across the board are the psychosocial hazards that we're exposed to in healthcare. A psychosocial hazard is any work-related factor that is perceived or experienced by the person exposed as a threat that causes them to behave differently, causes my amygdala to fire up, my prefrontal cortex to kind of shut down and go like, hey, that's a threat.
Dr. Daniels, thanks so much for joining me today. Appreciate it.
It's my pleasure to be here.
And so what is workplace safety? Like, how do you approach that if you're going in for a new consulting or even from like a ground up build for an existing workplace?
That's a good question. I guess I would connect it to Maslow's hierarchy. So Maslow's hierarchy of needs, many of us heard about it either in high school or college or, in our first leadership role. It's that basic concept that suggests that we have these needs, and the first need is, can I breathe? Do I have air, water, sleep? The physiological needs that just keep me going. And the next step up on the hierarchy is safety. So for me, it's how do we create that second hierarchy in the workplace? Because it doesn't always exist to the extent it should. And I don't attribute that to intent at all, because a lot of conversations about safety tend to get focused around what individual human beings do that cause them to be injured or other people to be injured or things to be broken. And it's a lot bigger than that. A lot of this is about the systems and the cultures that exist within those systems that cause people to be exposed to things that are going to get them hurt, other people hurt, or things broken. And I think we spend, even in the workplace, sometimes too much conversation about, well, how do we fix or change this person? And how do we fix or change this environment? Because that person is who they were created to be. They are who they are. They bring things that might be beneficial to us. They bring things that might be liabilities as well. But people aren't good or bad to me. People make decisions to do the things that are in their interest at the time with the information that they have. We have a lot more control over the environment that we put people in, meaning the rules that we put in place, the work that we decide to do, the risk that we're willing to take from recognized hazards. So my conversation about workplace safety is, again, how do we, and I guess I say we, not how do I. It's not, I don't have a magic wand to walk into some organization or environment and fix everything. That I had hair when I thought I could do that. But through therapy, I come to recognize that my role is to help, not to fix. As a safety professional, I can't make people be safe. I can help provide information so they can make a decision about their own life and their own decisions, and hopefully some of those decisions will be safer for them.
And so it really starts, I guess, with the culture emanating upwards. Like, how does a company set culture that way? How do you make safety an important?
Well, it's the same way you make money a factor. Intent. A lot of organizations, a lot of social settings are hazardous because they were designed to be that way. They were designed, and often when people think about, a lot of these conversations come up, quote unquote, around business, but I spent most of my working life in the public sector. And it wasn't necessarily about making money. It was about doing the right thing. I was in the fire rescue service for 3 decades. And I don't recall ever pulling up to somebody's house on fire, with asking for the credit card. If I'm getting ready to do CPR on somebody, I didn't, as, are you a member? It was, I'm here to help because you called me to help, and I'm here to take care of, this situation so you'll be better off. That's why you called me. And because that's been my upbringing. I started in the fire rescue service a couple of years out of high school. It was the first career that I had. I had lots of jobs before that, but that was the first real career. And that kind of has become part of me. I've only done a couple of, maybe 2 or 3 private sector jobs in my life, since being an adult. And I didn't enjoy either one of them because there was so much focus on making money that, in my view, they weren't necessarily getting the work done because they were focused on trying to make money. And so they got the inverse. They got people hurt and things broken and other people injured because they were so focused on making money. And so I just really believe that you get the culture that you seek. If the culture is about money at all costs, that often involves exploiting other people, getting as much as I can get out of you, but you don't get a whole lot out of me. If the goal is for us to accomplish something, so we want to accomplish something, but we want to accomplish it in a safe and effective way. Once we set that intention, we're going to continue to do that thing. So I won't sacrifice your safety to make money because the money isn't as important as your safety. And it becomes it's second nature.
And that has to start with the leadership then, setting that culture.
Right. Yes.
Because I've seen both sides of it. Like before getting into medicine, back in my younger years, I do landscaping, and definitely like the companies I worked with were always, it was like you wore it as your badge of honor doing something sketchy, with a bobcat or the other equipment. You're like, ooh, this is kind of thrilling cowboy stuff. And then a few years down the road, I actually met a fellow who works with Graham Construction, and they are just hearing him talk about safety. It's like a complete 180. In terms of like, I don't want to be the one that has to talk to your wife and tell her what happened today. And it's just like completely black and white difference, like the kind of top down leadership setting the safety culture in an organization. Why do you see such polarizing differences between companies?
It does. Again, it goes back to who started it. Everything was started by somebody, Now, we could get more philosophical and talk about the creation of the universe, the evolution of human beings. I'm not talking about going back that far. More recently, these organizations were started by somebody with some intent. Again, I don't necessarily know what it is, but what I do know is we tend to, when we know better, we do better. And most of the systems, at least that I was exposed to, safety was not the priority. I had to learn over the course of my life how important safety was. An example was, again, in those 3 decades in the fire rescue service, 30 people that I worked with either got killed at work or died from something they were exposed to at work. And I never got physically injured, not a single solitary time. So the difference was I made decisions for myself that kept me physically healthy and safe. But I did get psychologically injured a lot. But again, it's because I didn't really recognize that that's what was going on. After I started to recognize it, I went So the other thing I mentioned is there's a difference between doing safety things and feeling safe. They are not the same thing. And I do believe that many of us, based on all kinds of things, have been almost value culture to push past how we feel. And that's the challenge. Our bodies are set up, and you know this certainly better than I do as a medical doctor, that our bodies are set up to keep us safe and healthy. That's how they're designed. Our brain, the most elaborate computer ever conceived, in history, is set up to keep us safe and to keep us, living as long as possible. And we have, by practice, push past what our brain is telling us. So it's like when I was a kid, if I reached up and touched something that was hot, my brain, that's hot, and my body recoils. It says that's not a good thing, and that's a lesson that I learned. But again, we've been put into, either put ourselves or other folks put us into situations where we've been told, "Oh, don't worry about that." I know that, no pain, no gain, that type nonsense. And I just don't, from a safety perspective, I don't believe in that. I believe that safety is, if I don't do the safety part right, I can't self-actualize. My self-esteem is certainly going to be affected by how safe I feel. My sense of belonging is going to be affected by how safe I feel. And so again, I think we skip over that too often and get to, oh, let's talk about belonging. And I can't get there because I don't feel safe. And again, if I do things that cause me and others to feel safe, the safety activities will certainly line up behind that field.
This podcast was brought to you by Cherry Health, the healthcare jobs network with over 35,000 jobs across Canada and the US. Physicians, nurses, pharmacists, and all other healthcare professionals can sign up for free. Start connecting, messaging with colleagues, or checking out job opportunities posted by thousands of employers across North America. With dozens of healthcare-specific job filters and search options, we make it easy to advance your career, find your dream job, or line up your next locum, with thousands of new jobs posted every week. www.cherry.health to get connected today. When it comes to safety in healthcare culture, I don't usually think of it as physical safety so much. When you're thinking of the hospital or a clinical setting, versus standing on the end of a bucket, reaching up out of a skid steer, trying to grab something dangling over top of a precarious situation, versus what should we actually be looking for in terms of making a person feel safe and setting the safety culture within healthcare organizations?
So first of all, I'll share with you that a lot of our conversations around safety have been too focused on heavy industry, construction, public safety, transportation, manufacturing. They get all the discussion about safety. And I think that we've done that as a society to our own detriment. Every environment has hazards in it. They all do. They all do. And it's not about the industry. It is about, can I recognize the hazard in this environment, the degree to which I'm vulnerable to it, and the associated risk with that vulnerability? So those concepts are really important. Hazard, vulnerability, risk. They all go together. And what I find is that folks skip over the first two, and they want to talk about risk management. Well, how can I manage risk when I don't know the source of the risk? I don't know where the risk is coming from. I just know that, and I look at the outcome, or someone slipped and fell, someone was exposed to a chemical, someone, contracted MRSA. I mean, pick your thing, but there was a hazard that we did not identify on the front end, and a degree of vulnerability that we did not assess that caused us to have risk in the first place. So I would say to you, in healthcare, if I were to do a job hazard analysis, and that analysis really is not a difficult thing to do for those of us who know how to do them, the first thing I want to look at is the environment that the person is going to operate in, and what hazards are they going to be exposed to. Some of those hazards will be physical, but a significant number of them I'm going to venture, because I was involved in the pre-hospital healthcare system as an emergency medical technician. So same industry, just on the outside of the doors of the hospital. I had more physical risk or more physical hazards I was exposed to. But what's consistent across the board are the psychosocial hazards that we're exposed to in healthcare. And so generally, I separate hazards into two categories: physical ones and psychosocial ones. We know a lot about the physical ones: biological, chemical, ergonomic, slip, trip, construction, natural. You pick them, but they're mostly about the physical manifestation of something that could potentially bring me harm. What we don't have a lot of conversation about, which is really important in healthcare, and in any non-heavy industrial type of environment, are the psychosocial hazards. And my definition of a psychosocial hazard from my research is a psychosocial hazard is any work-related factor that is perceived or experienced by the person exposed as a threat that causes them to behave differently. Perceived, something I comes in through my eyes, ears, nose, mouth, you know, my skin, whatever. I perceive it as something that, based on my experience, could potentially harm me in the future. So to you and to me, psychosocial hazards are going to be very different. Some will line up exactly the same, but some are going to be very different because of my experience. My perception may be identical to yours, but my experience of that same thing is different, and it causes my amygdala to fire up, my prefrontal cortex to kind of shut down and go like, hey, that's a threat. I need to figure my way through this before I can have a otherwise intelligent conversation with you, because there's something going on that doesn't cause me to feel good. Back to that conversation about feelings. And so again, and then if I assess, or if my, experience of this is such that it is at a level that I need to do something different, that's when it becomes a hazard. There are hazards all over the place. There are things going on. I'm in a building right now that's built of wood. Well, I'm not worried about it because it also has brick on it, and I don't have a lot of fire hazards around, so I'm not worried about it burning down. So I don't have to change my behavior. But from a psychosocial perspective, we could be so we go into a patient's room. You're the medical doctor. I'm the orderly. And I don't have the expertise in terms of the patient's condition that you do, and they do something that surprises me but doesn't startle you. Or it might be just the reverse. You're in my environment, we're in the supply closet, and I know where these chemicals are, but you don't. You know about medical doctoring, but don't know anything about this chemical. You go, what's that? Because of your experience and your perception. So again, it really matters how we see things and how we've experienced them in the past. And that causes us to have a reaction to it.
And then the difference in reaction, is that sort of now you might be operating outside of the standard operating procedure? You're stressed or concerned in some other way,
Yes.
Distracted, and that's when mistakes start to happen?
Yes, absolutely. Again, we have reactions to things based on all kinds of, it may not be anything about the workplace. It may be something that came to work with me that's going on at home. And so that's why this is such a broad conversation when we talk about psychosocial hazards. The issue isn't the fact that the hazard exists. The issue is, what do I do about it? Because I cannot eliminate them all. I can engineer out most of your chemical hazards in your environment. I mean, there's engineered controls I can put in place that it's around, but we don't have to worry about that because it's in a pipe or it's got a valve on it. It's got this. We don't have to worry about those as much. But psychosocial hazards cannot be totally eliminated. So we have to be able to identify them, assess how vulnerable the particular person is, and then what are we going to do about it? So when the person says that I am fearful because of what I just saw, I am stressed because of what I've been experiencing, that's when the work really starts. So what do we do about that? And there's actually a psychosocial hazard hierarchy of needs. We can talk about that helps us kind of identify how we're going to deal with the hazard, because can't eliminate them all anyway.
So what I'm hearing then is, in healthcare, like, it's not so much the physical risks. Like, we're getting pretty good. It's kind of table stakes at this point in terms of infection control and sterility and wearing your PPE. It's more around the psychosocial side of things, and burnout and the suicide risk, I think, is probably the big one that people talk about. What else is there to that side of the psychosocial risks that we should even be looking for?
So again, psychosocial hazards exist in three environments. One environment is the work itself. So when whomever opened up that hospital, now again, often some doctor, medical professional decided some period of time that we need better healthcare in this community, so we open up a hospital. They don't necessarily do it focused on hazards. They do it based on providing healthcare, just like people open up a grocery store or a construction company. And again, that is a part of the challenge, is that when we started the thing, we didn't consider. This is why folks like me as a safety consultant, I like to be involved when you're starting something, not after you've had a problem. But it's like when I was in the fire service. People call me when a house is already on fire. I could have helped you design the house so it wouldn't have burned in the first place, but you didn't. So now we have to deal with the consequences. So anyway, the work itself has hazards associated with it. Then also how the work is designed. Also, there are hazards associated with how we do the work, not just the work itself, but how we do it, how many hours we work, how many people we have, what days of the week we're open, all of those kinds of things. And then the third category where these hazards, psychosocial hazards, exist are the people themselves. Because of the way I see the world, the way I behave, the way I speak, the way I look, the way I interact with other people, my behavior could be a psychosocial hazard to someone else. And again, there are unfortunately, it's not really unfortunate to them. There are people who see me, and because of their life experience, they get a little nervous because they see me, because they've not been in the presence of a person who looks like me or talks like me or enjoys the things that I enjoy, or has been trained that there's something nefarious about me, or I don't belong here. And while they don't necessarily say it, their behavior suggests that they've been exposed to it. So if I come into the room and I am taller than everyone else, or shorter than everyone else, or I have a mobility assistance device, or I speak a language that they don't speak, or you pick it, I'm different from everyone else in the room. There are ways that, I've heard about these folks. So I start talking louder because the person's in a wheelchair. Well, it's not that they can't hear. It's that they need a mobility. Their legs don't work the same way that mine do. But you see what I mean? So these are things that cause us to behave in ways that are really protective to ourselves, but can be perceived by other people as at least annoying, and in some cases even threatening to them.
It's interesting you bring that up, because they cover this in medical school a fair bit, sort of that approach and like the softer sides and the social cues. And then in medicine specifically, you get this like interesting amalgamation of kind of the stereotypical book nerds who had the high GPA, but definitely are a little bit lacking on the social skills side of things. And then you put them in these very like personal relationship type of roles, and you tend to get a little bit of friction.
You do. And again, we are all simply different. I mean, we're different. And what we've done in many of our systems is we have established a prototype for whatever it is, and everyone gets measured against that prototype, which is kind of weird sometimes. It's kind of weird. It's particularly weird for those who don't fit whatever the prototype is. And so medical schools were started by somebody. And so everything that I start is really great for me. It's really safe for me. It's really comfortable for me. It is, and I tell folks often, I do everything perfect for me. The challenge is it's not perfect for everybody else. To include the woman I've been in a committed relationship with for the last 37 years, not everything I do is perfect for her. It isn't, and I had to kind of figure that out. It took some years to figure that out. But I thought, if I like it, so she'll like it. Well, no, she doesn't, and that doesn't mean that there's something wrong with her. It just means that we're different. The same thing applies to healthcare settings, to construction companies, to banking, to whatever, is that these systems were established by somebody with this prototype that says, this is the way I want it done, so everybody follow me, as opposed to having all of us contribute. So you invited me to this party, but you didn't give me any, I didn't get any say on what's on the menu. And I don't really eat that thing or like that thing. And then I have to conform to that. And that's sometimes difficult for me to be something that I'm not. So the medical instruments were set up for people who tend to be right-handed. This type of machine is set at a particular height because the person who made it was 5'8". There's all these things that we do, and again, these I'm not suggesting that they were done with some sort of discriminatory or negative connotation. They were done safe for the person who created them. The question is, how do we make them safe for people who didn't create them? How do we create this kind of inclusive environment that says, if I invite you to this party, the first thing we do is, what types of things do you like to eat? Or I advertise up front what we have to eat, and then you can decide whether or not you want to come to this party.
What other common faux pas do you see on that front in terms of making everybody feel included? Like the food and dietary changes definitely makes a lot of sense. I can imagine that probably comes up a lot. Like, what else do you actually see from those types of issues?
Well, first of all, I think the issue is we don't think about it enough at the beginning. And why are we having this thing? We're having this thing, have we established this with the intent to be safe for the people who come? Often we just don't think about that at all. So we don't consider anything else because I'm doing this thing, it works for me, and I invite a bunch of people. As opposed to, well, I'm doing this thing and I want it to be comfortable for. Now, again, you can go too far the other way, and you can't make it perfect for everybody because that's not possible either. It's just not possible because we are so different. So if the intent of this gathering or this organization or this social setting or this job or this business is, one of the underlying values is I want it to be safe for people, is I have to, again, do that job hazard analysis on the front end. And then be transparent about what it is and not call it something that it's not. And the example that I use, so here in the States, we have and have had since the Civil Rights Act of 1964, this concept of equal opportunity employment, which sounds good, but in practice is nonsense. It's never going to be equal and opportunity for the folks when the system itself wasn't built for that, whoever that group is. And again, I use my experience in the fire rescue service in the United States. And the last figure I heard was that, for example, from a gender perspective, that 4 or 5% of the American Fire Rescue Service are female. That's about half of the percentage in the United States Marines. So the Marines can find women, but the fire service can't seem to find them. And it's not that they can't find them, it's that the system wasn't designed for or by women. So it has all of these invisible barriers that are in place that make it difficult for women. And we do that for everything. We put these things in place that become barriers for the very people we say we want. So in order to make it safe for everyone, or make the environment as safe as reasonably possible, it's who are we inviting to this thing, and what are the hazards they would be exposed to, not I would be exposed to, and how do we mitigate the hazards that exist in this environment for them? Not how do they do it on their own. So again, a little saying that I picked up, I read this book a while back and kind of converted a little bit, but safety doesn't work well when you do it to people. It also doesn't work well when you do it for people. It works better when you do it with people.
Yeah, it's got to be that collaborative team approach. Everybody's bought in.
Yes. And who's not going to buy into us being safe? The question will be about
safety.
how. That's right. The question will be about how we do it. But no, I haven't met anybody yet who says safety doesn't matter to me. But often the issue is we just perceive the hazards in our environment differently. So the risk that you would take and the risk that I would take, I have been into buildings on fire. I don't think it's even all that risky. I really don't, because I know how to do it. Seriously,
yeah.
It was fun. And if you ask most firefighters, and most of them, you don't even have to get them drunk to do it. They'll be honest and tell you it's actually fun. But it's because you're so well trained on how to recognize the hazard. You have the PPE, you have the knowledge and skill about how fire builds and how it travels. So to you, it isn't an issue. To most other people, it's a big deal. Just like firing a weapon. I've fired a gun once in my entire life. To me, it's extremely threatening. It's extremely threatening. But to other people, it's like they'll go out and shoot guns. And, to me, I've lost two relatives to gun violence. So to me, my experience is the conversation about the use of a gun is a psychosocial hazard for me because of my experience. And again, so I'm not saying it's inherently anything. It is to me.
And so when it comes to, I guess, the sort of the DEI perspective of the psychosocial hazards and the risks in the workplace, like bringing it back to the healthcare side of things, how do we make a more inclusive, equitable workplace? How do we make everybody feel more comfortable? And I guess it's also a little, I don't know, perhaps one of the smaller, unique pockets in the world where it's more of a female-centric workplace. Like right now, more doctors are women, nurses are primarily women. What kind of things do we need to consider socially?
So first, while many of the doctors and most of the nurses are women, we have to go back to who created the healthcare system. It was not women. It was created for and by men. So it is, again, being honest about that up front and not sugarcoating that and calling it something it's not. It was designed by men. So if we want it to be safe for women or pick the group that we want to be safe for, we have to recognize who designed it and recognize that it's not that perspective is bad, but it's different. So how do we adjust what's been established by men to be comfortable for women? And that's where the inclusion part comes in. It's inviting or involving women in the discussions about how the work is done, how it's designed from their perspective, and being willing to change how we do things with the intent of making it safe for women, or safe for Black people, or safe for non-English speakers, or safe for disabled people, or safe for the neurodivergent. Or so again, it's this ongoing process. I believe that every organization should consider their culture and consider their safety environment every year and revise it every year based on who's there for the next year. Every year. So we do that with our budget. Nobody has a budget for 12 years and never looks at it. It's just, we have an annual budget and we have these quarterly updates. So why not include our approach to safety as a part? It's an annual thing that we do. And we start off with addressing, first of all, who's here? What are the demographics? Who are the people that we've invited into this space? Because we often, and I saw this a lot in the pre-hospital side of the healthcare system, and I assume it's the same on the hospital side, we focus a lot on how do we make it good for the patient, but we forget
very heavy on that.
Heavy on the patient, but there's as the leader, as the administrator, my role is not to provide care directly to the patient, it's to create an environment so the doctors and nurses and staff can provide it to the patient. So why not create an environment so they feel safe? You can't take care of them because you can't take care of each other. That's where so a lot of even issues around workplace violence and such, a lot of that, it starts with the doctors and nurses. It's not just the patients. Often it's doctors or it's healthcare systems who set up this, you've got to work an 18-hour shift. That's humanly ridiculous. But somebody thought that that's the way we're all going to learn, is to keep these human beings awake for 18 hours and then wonder why they make mistakes. It's because they're tired. That's pretty simple. But my doctorate is not in healthcare, and I can tell you that. So it's basic things that we can create. And again, a lot of folks, and I'll certainly cover it because you mentioned it, there's a lot of people getting all tweaked out of the frame about discussions around diversity, equity, and inclusion. And that's not the issue to me. The issue is if we focus on creating an environment that is psychologically healthy and safe for everybody, we don't have to worry about diversity, equity, or inclusion. Because the thing that keeps it less diverse is that I don't feel safe even applying for that job. Why would I apply for that job? Yeah, I don't hire people like me. I know you don't. All I have to do is I look at all the pictures that are on the wall. You've told me that I'm not welcome here at the beginning, so I know that I can figure that out. And I told my brother and sister and people in my community that we weren't safe there. So if you were to create a safer environment, you'll get more applications. You'll get more people passing the entrance process, whatever it is. You get more people, wanting to be a part of what you do, and you get more people to stay if it feels safe to them. Not safe to you, safe to them.
How do we go about doing that? Where does that start?
Again, pretty simple. First of all, again, you have to want to, for real. Not want to for fake, but want to for real. There are a lot of people. So after the murder of George Floyd on the 28th of May of 2020, there was this global conversation about racial reckoning and Black Lives Matter and all that type of thing. And again, I talk about these things as a Black person because that's the one that I know. But the same could be said about, the the Stonewall uprising or women's suffrage or whatever. Pick your group of people. But I tend to pick the one that I tend to understand the most. So anyway, you have to, and so a lot of companies, a lot of organizations says, oh yeah, we realize this is a bad thing, so we're gonna find money and we're gonna throw money at it. And then 2 years later, they decide, well, now we kind of changed our mind because they were never really interested in doing something different. They were interested in doing something that looked different but wasn't different because the system itself a lot of it never really changed because underneath it all, it's like, well, we've got this system that advantages some and disadvantages others. So we don't really want to change that. We want to talk about the fact that we want to. So again, if I can help any organization get there if they're really interested. If they're not interested, I try to, so when I engage with folks, is try to help them be honest up front. And there's some folks I don't work with intentionally because I'm not here to convince you that that the environment should be safe for everybody. If you're not really, have you figured that part of it out yet? Well, let's talk later. If you're not concerned about safety at all, I'm probably not the person to talk to. Because again, I'm the person to talk to if, look, we know something's wrong. We believe it's safety related. We don't necessarily know how to do it. So we need your help. It's just like I have a primary care physician. I'm not a medical doctor. I know a little bit about anatomy and physiology because I was an EMT, but I'm not an expert. I have a doctor. So when when I go and do my annual physical, when I do my regular checkups, whatever they tell me to do, I do it because I get someone that I trust. And if they say, take this thing, I take it. I take their advice because I want to reap the benefit of their expertise. And so people talk about safety. Safety is everybody's job. Well, yeah, but they don't necessarily know how to do it. they don't have expertise in that area. So you need folks like me who do. I know how to do that. But again, I'm not here to arm twist anybody. I'm not here to shame anybody. My environment safe is yours. And I'm here to help. And sometimes that will cost you something. And that's why. So again, you have to have the intent. And then you have to get the expertise to do the thing that you say you want to do. And you can do some of it, but that's why we have experts on things.
And so I really appreciate like the not wanting to just do it lip service, right? It can't just be like a superficial, like, okay, we want to be more inclusive racially and gender and sexual identity, etc. But I'm like kind of having a hard time with what do you actually do then at that point? Like if it's the pictures on the wall being very like skewed demographically, like that's sort of the history of it. What do you actually do differently in the here and now then if you're trying to promote that type of safe and psychosocial safe culture?
Okay, so let's take that example. So first of all, those pictures are only psychosocial hazards to certain people. They are. So the organization has to decide who do we want this environment to be safe for. It's not going to be safe for everybody. It's just not. And we got to get out of this idea, sometimes the bleeding heart liberal do-gooder in most of us, we want to make this great for everybody. You can't. You can't make it great for everybody. You don't have the capacity to do that. So let's focus on who do we want it to be safe for. And so that might involve what are the demographics of the people who are here all the time? And then who are the demographics of the people that come here often that we want to come back? So that's looking at our staff and looking at our patients. Who do they look like? So if 100% of those people are white men, then we're good. If 100% of them are white people, then we're good. If 100% of them are Canadian, but it's not 100% of anything. So it's taking and slicing and dicing those groups. So there are a certain percentage that are men, a certain percentage that are women, a certain percentage that are indigenous, a certain percentage that are able-bodied. And again, we may find the top 10 or so of these groups. And then we go to, like we do market research on everything. I have an instrument that I created in my research called the Psychosocial Hazard Inventory. And you simply ask people, what about these things? What of these kinds of psychosocial hazards have you been exposed to here? So again, we're assuming in this case you didn't start this thing from scratch. Starting from scratch is a lot easier. New construction is a lot easier than remodeling. But most of these are remodel jobs. So I go to the group of people that are there and simply ask, which of these things are psychosocial hazards that you've been exposed to frequently? Or that you've never even heard of before. We take maybe the top 10 or so, and we go, these are the top 10 across the board for everybody who's here. And now, how do we address these psychosocial hazards? And it may not be the pictures. Nobody's noticed those. But it is the fact that we have role ambiguity is a psychosocial hazard. Why? Well, one of the contributing factors is we don't have very good job descriptions. We haven't told people what their base jobs are. So we find people kind of bleeding over into other people's responsibility. And I feel a little threatened by that. And they feel, overburdened by having to do someone else's job. So we address that. See what I mean? It is a really broad conversation with some very specific fixes. And some of the fixes are free. They don't cost anything. It's like, maybe we should just stop addressing this person this way because they said it doesn't work for them. Maybe we should allow people, now again, this is an environment where we have to protect them from the biological hazards that exist in the environment, but why is it that they have to be clean shaven? What? A little bit of a sidebar before I'm off on this rabbit trail. Most requirements around shaving have to do with respiratory protection. That concept of being clean shaven to wear a respirator was created in World War I when I think it was Gillette razors sent razors over to folks in World War I. It was in their little kit, and they all were using them. And then they thought this is a cool idea. And we've come up with this concept that says in order to wear a respirator, you have to be clean shaven. Well, no. We have positive pressure ventilators now, respirators now. There's all kinds of reasons why it's not necessary. What we have to do is protect you from the respiratory hazard. So there are folks that are designing respiratory protection that'll go around a beard. So if a person doesn't shave, particularly for religious reasons, that we can also give them a respirator. You see what I mean? It's thinking about what is the hazard we're trying to protect you from, not how we do it.
That's an interesting way of looking at it, because especially here in Canada, where it's become like sort of a core part of the culture and the identity of being Canadian is just how diverse it is of a population, the melting pot and the like smorgasbord of different nationalities and demographics you get here. And it will probably be very individualized in terms of what ways do you feel psychosocially unsafe in the workplace?
That's exactly right. So I'm a big NFL fan. I like pro football more than I like college. And in the NFL, football players' helmets and shoes are designed specifically for them. It's not a stand. It's designed for your foot. I believe that all protective equipment should be designed for the person. I also believe that from a psychosocial hazard perspective, that the mitigation strategy should be designed to the person. Because the hazard is a hazard to me. I may be the only person in this environment that sees this as a hazard. So there is no standard approach to addressing me. There's a standard approach to addressing hazards when they come up. That's the issue. And it might be totally different. And again, we should put the power and the ability to fix it at the lowest level possible. What is it that I'm empowered to do to fix or to address the hazard that I've perceived? You see what I mean? So I don't need the CEO to address it. I need to feel like I can address it. I need to feel like that when I walk into a room and I'm the only person in the room who feels threatened by this thing, that I can bring that up and everybody in the room, their heads won't snap because, oh, how dare you? It'll be, oh, how do we make this more comfortable for Jordan? Because Jordan's in the room with us and we're concerned about Jordan's psychosocial health. We're concerned about how Jordan feels in this environment. And we're always concerned about it because what is healthy and safe for you today might be threatening to you tomorrow because you've changed.
And so it evolves over time.
It evolves. It's a constantly evolving conversation. Safety is not some point that we get to. It's so Arthur Ashe was a great tennis player here in the U.S. and he said that success is not a destination; it is a journey. Safety is the same way. You don't ever get totally safe. It is a journey. It's this constantly evolving conversation about what causes me to feel safe today in this environment. It can change from moment to moment. But again, that sounds woo-woo and complicated, and it isn't. It's just being aware that this is a constantly changing thing, so my approach to it has to constantly evolve based on the environment that I'm in.
And then I guess, I don't know, Canadian versus US, is there a difference in terms of the psychosocial safety? What have you noticed in terms of the cross-border changes?
Yeah. I have a number of what I consider to be good friends at this, even though we've only met a handful of times. So Canada was the first country on the globe to create a standard for psychological health and safety. It was created in 2013. It's constantly, every 5 years or so, is being reevaluated. And so it was created by the Mental Health Commission of Canada. And it is after 10 plus years, it's become more of a conversation about psychological health and safety. We don't have that here in the States. We are still trying to get people to recognize that psychosocial hazards even exist. A little bit of a plug. That's why I have a book I've written that'll be out in the spring of 2025. And the title of the book is Psychosocial Hazards Are Real. It's written for the U.S. audience because I'm trying to convince people it's a thing. You're not going to approach a problem that you don't even believe exists. So I'm trying to convince people, yeah, it's a thing. And psychosocial hazards and physical hazards are both issues that we should be concerned about. In Canada, there is a much greater focus on this concept. As a matter of fact, there's a group of people that I do some work with. I'm not at liberty to even tell you who they are because that's the way but they're really focused on figuring out better ways of having conversations about psychological health and safety. There are trainings, there are certifications available. There's lots of things. And I will tell you that Canada and Australia are leading the globe on this conversation. Canada, from a standards kind of approach, it's a kind of a softer, we want to encourage you to do the right thing. And in Australia, there's a law that says you will do it. Now, what I'm observing is, I'm not saying that either is better or worse than the other. They're just different approaches to the same thing. And I believe that there's value in both. People do things from a safety perspective for one of three reasons. Number one, they have this moral and ethical belief that it's important. Number two, they think it's going to save them a buck. Number three, they have to. In the United States, I really have to focus on the number one people, the people who think it's a good idea. Because there is There's some data, but there's not as much data. And if I can't connect it to physical things, people won't listen. And there's certainly no law here. So it's a very different conversation across borders.
And so when it comes to the book that's coming out right away, what's the audience that's geared towards? Is that for the smaller organizations, the larger organizations? Is it for the people that are the employees? Is it for the leadership?
So this book is actually written, I call it 2.5 books in one. The one part of it is some personal stories about why I feel the way that I feel about. So it's not really autobiographical, but it is from my perspective, because my perspective is unique. Again, in the United States, when I finished my dissertation and received a doctorate in occupational health and safety, at the time, I was the only Black male that I could find in the entire country with a doctorate in occupational health and safety. The only one. I've since found one other person. And that's really, when you're talking about onesies and twosies, there may be a few more now. There were some Black women, and there is a small percentage of Black people, but it's just not a lot. So I have a very kind of unique, and on top of that, my fire rescue background is really, really different from most people in the safety profession. A lot of people in the safety profession, they went to school, they have the theoretical. I can tell you stories about what happens when you don't do things safe, and they're really gory and really. But so I started at the lagging end of the system and worked my way back. So my story is important to me, which is why I wrote it. It is also a conversation about psychosocial hazards specifically. There is an international standard, ISO 45003. That was published right about the time that I was doing my dissertation. And so I used the standard as a reference, and my book is kind of structured around the standard as well. It doesn't, not exactly, but I try to use the 88 psychosocial hazards identified in this international standard, and I talk about all 88 of them. I go into more detail than the standard does. The standard says this is a thing. I talk about why it's a thing, at least from my perspective. So and then the half of the book is what do you do about it? Because it is impossible in any one book to write solutions to all of the mitigation strategies associated with psychosocial hazard exposure. It's just not possible. So I try not to be naive to say, yeah, if you do this, you'll solve it. No, if you recognize it, then maybe you'll start to solve it. So people will sometimes leave with more questions than answers, but that was the point, is to get you to think about how are you going to address this for you. So this book, if you're an expert, you'll find something in it. If you've never heard of it before, you'll find a lot more. If depending, you can be, I think a lot of my fire service colleagues are going to like it, but you don't have to be in the fire service. I think my safety professional colleagues will like it, but you don't have to be in the safety profession either. So I've tried to write it such that I think some people will read certain parts of it, but I don't know that I'm going to find anybody who read it from cover to cover and really relate to all of it. But that's the way it's written. I think it's going to be interesting. But again, I wrote it because I wanted to tell the story, and so I am.
Well, it probably opens up the door to conversations. Like I do a lot of like psychotherapy and counseling for patients, and it really starts like if you're trying to change a habit, if you're trying to change a lifestyle, if you're trying to change cognitive distortions, it starts with recognizing things, right? Yes. Or if you go back to like the 12 steps of AA, it's the admitting, recognizing there's a problem. And so it really starts with opening the door to just having those talks and trying to figure out, is there a problem?
That's right. Yeah, there is a tremendous industry around wellness and fitness, and there's therapy, there's all these things that are going on, but they're at the back end of the problem after people have been exposed. And if we're talking about the workplace, because a lot of my book is focused on the workplace, it doesn't have to be that way. It doesn't. I'm hopeful someone will take this book and go, look, we're a startup, we're a new organization, and we want to look at this from the start, and we want this to be psychologically healthy and safer from the start. But we didn't recognize that was a hazard, because again, you can't have everybody in the room at the same time. But these are things that a person could read and go like, oh, I didn't recognize that was even a hazard. And I know that, well, at least I believe that the people we're probably going to hire will probably see it that way. So let's address it before they show up. Let's have those conversations when they show up. Let's have those ongoing conversations as we keep them in the fold. So yes, it is about getting people to recognize it's a thing. Once we recognize it's a thing, then we figure out what to do about it.
Amazing. Well, Dr. David Daniels, thank you so much for joining us today. I really appreciate the insights on psychosocial safety in the workplace.
Absolutely. My pleasure. My pleasure.